So welcome everyone. I want to go ahead and get us started this evening. I am Dr. Eileen Thrower and I am the interim department chair for the Department of Midwifery and Women's Health at Frontier Nursing University. And I'm so excited to see you all here this evening. And I'm really excited that you've joined us this evening as part of FNU's Empower 2021 virtual event celebrating National Midwifery Week. So this week we're celebrating all midwives for their passion, dedication, and the impact that they make on their communities across the country. Tonight we have with us Dr. Daisy Goodman, a certified nurse midwife and FNU graduate, who will be presenting the session, Creating a Culture of Respectful Care for Pregnant and Postpartum People with Substance Use Disorders. Dr. Goodman is an associate professor of obstetrics and gynecology, community and family medicine at the Geisel School of Medicine, and a practicing nurse midwife with 20 years of frontline engagement in the management of pregnancies complicated by drug and alcohol use. Dr. Goodman earned her midwifery certification at Frontier Nursing University, a doctorate in nursing practice at the MGH Institute for Health Professions, and a master's in public health at the Dartmouth Institute for Health Policy and Clinical Practice. Since joining Dartmouth-Hitchcock in 2013, she has been actively involved in the development of a system of care for pregnant and parenting people with substance use disorders. Her area of clinical research and improvement focus on the intersection of trauma and substance use and their impact on maternal and infant outcomes, and on engaging patients in the co-design of services to meet their needs. She is a co-author of the Alliance for Innovation in Maternal Health Patient Safety Bundle for pregnant and postpartum people with substance use disorders. So it's my honor to turn the session over to Dr. Goodman.
Thank you so much. It's a pleasure to be here, especially because it's FNU and especially because it's Midwifery Week. So I'm happy Midwifery Week, everybody, and I'm so happy that you're here and that we're midwives. So I don't have any financial conflicts to disclose. I have a lot of acknowledgements, way too many to enumerate, but most of all, I want to thank the patients that I have the privilege to work with, because truly they fueled my desire to do not only clinical practice, but also research. And they teach us every day what they need in order to take better care of them. So they truly are sort of the root of what I'm going to talk about today. I do have some funding to disclose. This is all federal. I have two HRSA funded grants, one about bringing people who are pregnant into prenatal and postpartum care earlier if they have substance use disorders, and the second one is about creating a better system of care for families impacted by SUD. And then I also am a co-PI on a PORI funded study looking at models of care. So I don't know where you all are located, but I want to start by acknowledging the fact that I am to you from what is now called New Hampshire, which is unceded Wabanaki Confederacy territory. And I want to talk just a little bit about how sort of my positionality with regards to this work, because I grew up in New York City. And at the beginning of sort of in the 1960s and 70s, and this was at the beginning of another wave of the opioid epidemic, which we call the opioid epidemic now, but it's not. It's an iteration of multiple waves of rising opiate use and opiate the impact of opiate use in our communities. And that is in itself part of a long trajectory of substance use and the impact of substance use on society in the United States, and before it was the United States, in the colonies. And that started with the first weaponizing of alcohol in Indigenous communities by the early English settlers. So I think it's really important to sort of position when we talk about perinatal substance use to really look at it in a historical context, because this has been with us for a very long time, and we really need to figure out some different ways to work with it. So here's the agenda, what I thought we could talk about today. First, starting with sort of the prevalence and implications of perinatal substance use, and then moving towards talking about what we know about evidence-based treatment modalities. And I'm going to talk about substance use disorders generally, but really focus in on opiate use disorder because it is sort of one of the most prevalent substance use disorders that we're seeing right now in this country. And then I'll talk about models of care. So if we know what the evidence base is for treatment, how is the best way to deliver that care, right? Should we deliver it in one model or another model? We'll talk about some patient perspectives on that from research, and then clinical outcomes associated with different models of care. Then move to what this all tells us about the policy changes that would be good to make. And finally, I'm going to touch on the Alliance for Innovation in Maternal Health Safety Bundle. I was hoping that it would be completely, the wording would be completely finalized and I would be able to actually go through all the details of the bundle, but it's in the final approval stage. And so I'll talk about the content, but I can't actually talk about the actual wording because it isn't final yet. I really want this to be interactive. We're not that big of a group. I'm very open to having people put comments in. Arlene, I see that you have raised your hand. Do you want to say something? Oh, can we get a copy of the slideshow? Yes, absolutely. Yep. I'll also stop sort of at each stage of the agenda here and ask if people have comments or questions or clarifications, because I'm hoping that we can make this more of a discussion than me just lecturing for an hour and a half. Should probably put you all to sleep. All right. Try that. All right. So first, just a little bit of scope and terminology. So this discussion is not about the impact of substance use on pregnancy. It's about substance use disorders. Those are two different things. If somebody uses substances, it doesn't mean that they have progressed to having a substance use disorder. And I will talk about what the difference between those two things is and why one thing can lead to it, or how one thing can lead to another in terms of brain chemistry. I will do my very best to always use person-first language, such as people who have substance use conditions or people who use drugs, rather than using more pejorative words that we all unfortunately learned from the world around us. Similarly, I like to use the words non-prescribed substance use rather than drug or alcohol use, although I will also say drug or alcohol use. Most of all, this is important when we're talking about, for example, drug testing results or toxicology results. We never want to use words such as clean or dirty, but just the toxicology was positive, it's not positive. So being really descriptive and trying to be person-centered in the language that we use when we talk about substance use in pregnancy. And then, as I mentioned, this concept of the opioid epidemic is really a historically inaccurate concept. We're in another iteration of an ongoing issue with opioids that we've had for a long time. All right, so talking about prevalence. First, I just want to mention that we have some available data on perinatal substance use and substance use disorders, but none of it's perfect. So it's really hard to get our hands around really what is the prevalence of substance use for pregnant people in the United States. We have the National Survey on Drug Use and Health. That is a nationwide survey. It's retrospective. It's self-reported. They do their best statistically to sort of mitigate the potential biases that are part of having a retrospective self-reported survey. And they do a great job. But again, this is really about what people's exposure was during pregnancy, like whether or not they used cannabis or opioids or alcohol or tobacco, but it doesn't tell us anything about substance use disorders. Now, some people have said, if you have, if you use a substance and then you continue to use it when you're pregnant, doesn't that mean that you likely have a substance use disorder? Because most people know that substance exposure is not good during pregnancy. And so if they're unable to stop, does that mean they have a use disorder? I would say that's a hint for sure. It's not the same thing as a diagnosis, and we'll talk about the diagnostic criteria for substance use disorders in a later slide. The CDC has a drug abuse warning network, DAWN, which is emergency department data about opioid-related admissions, for example, to the ED. That's certainly really helpful in telling us sort of what the hotspots are and what the drugs are that people are being exposed to that are causing them to come to the emergency department. So it's kind of a great warning sign at a warning system. We can look at maternal and neonatal discharge data. There's a time lag with that. Depending on the state, it can take several years to get those data back. And unfortunately, we can only use those data to know who's been diagnosed and who's been treated. So if somebody isn't diagnosed or isn't treated, or they are treated, but the diagnosis doesn't make it into the discharge coding and billing, then we'll miss those cases too. So it's usually an underreport, but again, it's useful data to have. Vital records data can be really helpful. In New Hampshire, where I practice, we have actually made a concerted effort to track perinatal substance exposure through our vital records. So we have a birth certificate worksheet. You're probably all familiar with filling those out at the time of delivery. So that can be really helpful data. Again, only those who are diagnosed or treated. And when we remember to fill that section out of the birth certificate, so nothing's perfect, but again, it's a good and helpful general prevalence gauge. And then there's the TEDS treatment episode data set, which captures people who are being treated and receiving state and in programs that receive state and federal dollars. It does exclude facilities that are operated by federal agencies such as the VA and IHS. So none of these are perfect, but all of them are helpful. And probably they're the tip, what we know is the tip of the iceberg in terms of perinatal substance exposure. These are the data that got everybody's attention sort of in the early 2000s. The fact that neonatal opioid withdrawal was rampant in bringing multiple babies into intensive care units. People got very exercised about this, and it sort of busted wide open our awareness of perinatal opioid use, at least. So these are HCUP data, so national billing data. These data are from 2017. New Hampshire didn't report that year for some reason, but we're way up there in the higher prevalence area, like our neighbors, Vermont, Maine, and Massachusetts. And I will tell you that our rates of substance exposure in pregnancy, and particularly opioid exposure in pregnancy, are much higher than this, 1.28 per 100. So this is 12.8 per thousand. So it'd be like 1.5%. Our rates are much higher than 1.5%, at least double that as a state. So the reason I think this particular figure is important is because it really shows that there are sort of areas of our country where certain types of substance use are more prevalent than others. And that has historically been true too. So there are sort of trends, demographic trends about who's using what, and geographic trends about where people are using what, that shift with time. But what is interesting to track and important to track is how policy is different depending on which community is being impacted. So the demonization of Black women, for example, during the quote unquote crack cocaine epidemic is in sharp contrast to sort of the sympathetic portrayal of white rural women with opioid use disorder. So it's really important to be aware of that. And of course, to fight any kind of discriminatory talk or practice whenever we see it. So potential consequences of untreated substance use disorder are significant for both the pregnant postpartum person and the fetus and newborn. So when somebody genuinely has a substance use disorder, so to the point where they have compulsive use of a substance and they're unable to stop, then it's likely that that person is going to be less engaged in prenatal and postpartum care. There's a high likelihood of concurrent tobacco use and often other substance use, cannabis being a big one. We see high rates among people who inject drugs of infectious disease such as HIV or hepatitis, both of which have potential significant impact on the fetus or newborn. We see higher rates of in-hospital morbidity and mortality. And then very frequently people have untreated psychiatric needs. And of course, there's always the risk for overdose and death. For the fetus and newborn, if the pregnant person is untreated, often we see poor fetal growth, a low birth weight, and higher intensity of neonatal abstinence, neonatal opioid withdrawal in particular, following delivery, and sometimes some developmental delays, and of course the higher risk for adverse childhood events. However, treatment is what really transforms these outcomes. So our goal when caring for any pregnant person who has a substance use disorder should be to encourage that person to access treatment if they are willing. And treatment really saves lives. So these are data from Schiff and colleagues of the population-based study in the state of Massachusetts. And they looked at overdose, both fatal and non-fatal, among pregnant and postpartum women, looking at all pregnancies in the state of Massachusetts. Unfortunately, they found that there was a low rate of treatment during pregnancy. Only 64% of these folks had received pharmacotherapy for opioid use disorder during that prenatal year, despite the fact that they were able to demonstrate that those folks who did receive pharmacotherapy had a greater than 50% reduced risk of overdose. So clearly this is a life-saving medication, but it wasn't available to a lot of people. And then they were also able to track associated factors to overdose, such as anxiety, depression, and homelessness. So what is our evidence base for treatment? Any questions or thoughts about prevalence, comments? Speak up or feel free to chat. Otherwise, I'm just going to carry on. All right. So before we talk about treatment, I think it's really important to ground ourselves in substance use disorder sort of definitionally. So this is actually, now that I told you that we like to use first language, this is from the American Society for Addiction Medicine. They do use the word addiction in their writing, and that's because they are an organization that's been around for a long time, and that's their name, and they use that word, and many people with substance use disorders also use that word. So addiction, they define as a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experience. So all factors, so no people are exactly alike, but these all seem to be factors that make people more or less vulnerable to developing a substance use disorder. And then they go on to say that people with addiction use substances or engage in behaviors, which could be something not substance use, right, that become compulsive and often continue despite harmful consequences. So that's sort of the short definition of addiction according to ASAM. Substance use disorders have often been described as a disease of dopamine release and uptake. So just a quick review here. This is a dopamine, this is a neuron, the end of a neuron, with dopamine in its terminal. And you can see here that the neuron following it has dopamine receptors in its membrane, and that they extend into sort of this interneuronal space. So when the appropriate trigger happens for this neuron, it fires, it releases dopamine into this space in between, and those dopamine molecules will stimulate the dopamine receptors on neuron number 2. And neuron number 2 is, for example, a neuron that might experience pleasure. So dopamine is the neurotransmitter that conveys pleasure. So the initial neuron could have been stimulated by something like a delicious meal, something like the smell of beautiful flowers from a garden, anything. When the dopamine goes into that space and can stimulate the receptors on the second neuron, that causes a trigger for pleasure. But the body recycles, and so dopamine is also uptaken, reuptake. There is a reuptake process for dopamine by which the dopamine transporters grab that dopamine out of that space, take it away from those receptors, and bring it back into the original cell. So it's not wasted and it doesn't dissolve in between the two neurons. It's actually like reused. But the use of drugs that causes a prolonged sensation of pleasure actually interferes with that reuptake process. So the dopamine remains in that intercellular space for longer, and it can stimulate the neurons on the dopamine receptors on the second neuron for a longer period of time. And certain chemicals, such as opiates, for a somewhat more complicated process stimulating the opioid receptor, also interfere with the reuptake of dopamine. So cocaine does this, opiates through the opioid receptor, psychostimulants such as methamphetamine. All of these interfere with dopamine reuptake, and therefore they cause the longer duration of dopamine and the triggering of a happy or euphoric sensation. So that's why people use them, right? Because they make them feel good. And everybody likes to have a dopamine surge, of course. The problem is that prolonged use of a substance that causes a change in dopamine, in the dopamine pathway in the brain, causes a change in brain function sort of more long term. So the receptor availability and reuptake is altered. And then after time, that stimulation and reward that's felt in the limbic system of the brain, where dopamine, where this sort of pathway of pleasure and reward occurs, actually starts to impact the way the frontal cortex works. So now somebody wants to use because they want to feel good again, and they have a memory stored in the cortex that says, oh, remember last time you used that? It felt really good, right? When tolerance occurs and somebody also gets withdrawal symptoms when they don't use, there's also an aversive behavioral modification that's happening. So not only does memory tell them that they want to feel good by using the drug again, it also tells them, and you don't want to feel bad because you don't want to have withdrawal symptoms, so you better use the drug again. So there's both a positive and a negative reinforcement that happens. And eventually the term that's used sometimes in substance use treatment programs is that executive function is basically hijacked by this process of fear of a negative reaction and desire for positive. So these are the DSM-5, the American Psychiatric Association's diagnostic criteria for substance use disorder. So this can be used for alcohol, opioids, cocaine, cannabis, any substance is often taken in larger amounts or over a longer period than was intended. So here's where the brain is starting to make those changes, right? There's a persistent desire or unsuccessful effort to cut down. So the person might say, wow, I really want to stop using that so much. It's expensive. It's really messing with my life. But now it's difficult for them to do that because of the changes in the brain chemistry that have happened. So then it starts to impact behavior and sort of activities of daily living, and people start spending a greater deal of time looking for the substance, using it, or recovering from it. They may experience cravings or a strong desire to use. Recurrent use starts to unravel things that are important in life, or the ability to fulfill major role obligations. And then even though those negative consequences are happening, the desire to use and the compulsive use continues. So these are the ways that in interviewing somebody who is using a substance, you can determine, is this person just using the substance, or do they actually have developed a substance use disorder? And this is really hard for them to give up, and they're going to need a lot of assistance in helping them stop using. Finally, tolerance. and withdrawal, which are associated with something like benzodiazepine use or opioid use, are diagnostic criteria, but not in and of themselves. So somebody can be tolerant to an opioid because they're being treated long-term with a pain medication, for example, somebody who's being treated for cancer. That doesn't mean the person has an opioid use disorder. It means they have a physiologic tolerance to the opioid, as long as it doesn't trigger all of the criteria 1 through 9. Tolerance in and of itself does not diagnostic for a substance use disorder, and the same with withdrawal. Any questions? The other thing is that for a person to be diagnosed with a substance use disorder, they have to have these symptoms for a year, unless they're pregnant, and then any of these criteria met can actually diagnose the substance use disorder. So it's important, I think, to just put this in the context of other chronic diseases, right? So that all sounds terrible, but we're not very good at managing chronic diseases in ourselves in general. So the progression for a substance use disorder, which unfortunately can end up being fatal, is quite similar to what happens with other chronic diseases. So self-management is really key to success. And these data here from JAMA are showing sort of the comparison of relapse rates, so non-adherence to treatment plan, right, between substance use disorders and other chronic illnesses. So people who have hypertension very frequently don't follow all the rules about not eating salt and taking their medication as they have been advised to. And same with people who have asthma. I mean, we don't always take our inhalers. We don't always do the things that we are supposed to do. We often don't quit smoking. You know, there are many things that we should be doing when we have a chronic illness that we're not self-managing very well. And substance use disorders are similar. They're chronic relapsing condition, and they require vigilance and adherence to plan. Unfortunately, they can often be deadly. And also, unfortunately, they often result in legal problems for people that really could be avoidable, I think, if we had a better approach nationally towards understanding this in the context of a medical condition that needs care. So when somebody has walked through the pathway of criteria 1 through 9 on the DSM-5, things really start to unravel. And so often when I see a pregnant person and most of the people I care for have either stimulant use disorder or opioid use disorder, and they usually have them in the moderate to severe range, which means they have 3 or more of those diagnostic criteria 1 through 9. This is the picture that we're seeing. So any one of these bubbles may be particularly salient. Not everybody's the same. So not everybody has housing insecurity, and not everybody has child protection involvement, for example. But any one of these things tends to be swirling around the patients that I see, and often it's most of them. So trauma experience is pretty ubiquitous, I would say, especially among women with substance use disorders. That is because there's a strong correlation between trauma and early substance use for women. We often find that things have sort of unraveled to the point where there's a lot of mental health needs that aren't being met. People may or may not have medical comorbidities such as hepatitis, which is hepatitis C is quite common in our area, and we're starting to see more hepatitis B now as well. And then people often have social determinants of health needs because they're unemployed long term, because they haven't been able to hold down a job. They now have housing insecurity. They may have food insecurity. They almost always have transportation problems in the rural area where I practice. And then frequently there is also justice system involvement. Interactions with community and family can either be positive or negative for people. Of course, if a community is a dangerous place for somebody because there are many people in their community who use substances with whom they've used in the past, who may even have been a dealer to them, or to whom they may have been a dealer. Sometimes being in the same community can be a real challenge to someone's recovery, or community can be helpful and nurturing and a safe place for people. So always true there. And I would say the same for the healthcare community, right? We can either be perceived as stigmatizing, unhelpful, and potentially dangerous in terms of child protection reporting, or we can be allies. The World Health Organization reminds us that services for pregnant and breastfeeding women with substance use disorders should have a level of comprehensiveness that matches the complexity and multifaceted nature of use disorders and the things that led to them. So if you're not familiar with their guidelines for the identification and management of substance use and use disorders in pregnancy, I really recommend it. They have a nice systematic review there of like screening modalities that are helpful and not helpful, great recommendations. It's really a great guide. I also want to bring to your attention, if you're caring for this population, the clinical guidance document for treating pregnant and parenting women with OUD and their infants, 2018 volume from SAMHSA. And for those who are interested, as I am, in how we can really think about pregnancy and substance use from a harm reduction perspective, this toolkit from the National Harm Reduction Coalition, Academy of Perinatal Harm Reduction, is a really great volume, and it's very patient focused, person first in its approach. So, and then SAMHSA has a number of tips to their treatment improvement protocols. These are all of these things here that resources that I'm showing here are available for free online. Just look for them. The tips, the treatment improvement protocols are multiple from published by SAMHSA, and they address a whole variety of substance related and mental health related issues. So really great sort of condensations of what the available evidence is. All right, the good news is that many of our patients really identify pregnancy as being the moment at which change, which had seemed impossible until then, became possible. And so this was one research participant who was a postpartum woman who had entered care for opiate use disorder during pregnancy, told me, I needed something like an anchor in order to really enter recovery, and she experienced the pregnancy as that anchor. So that gives us a big opportunity. However, there are also a lot of barriers to treatment engagement during pregnancy, and particularly after the baby's born. So I would say the biggest one of those is stigma. So substance use in either a pregnant person or a person who is parenting sort of earns them like one of the it's really one of the most stigmatizing situations that a person can be in. The judgment, even from other people who use drugs, is intense. And I've heard that from multiple women who've told me, you know, like I go to my treatment program and I walk through the door with my pregnant self and everybody looks at me like, what are you doing here? Right? Never mind that that's a double standard. It's a group that's frequently treated very, very poorly. And for that reason, there's a lot of mistrust of the medical system, quite understandably. There's also a lack of community knowledge about the safety and efficacy of medications for opioid use disorder, in particular during pregnancy and lactation. So people don't have anyone to turn to who can give them accurate information about the safety of treatment medications. Often substance use treatment providers are reluctant to treat pregnant women, which is terrible. And so therefore, people may be really reluctant to disclose because they don't want to be treated badly. The fear of child protection involvement is a huge deterrent to disclosure of use and need for treatment during pregnancy. And then, of course, there's the usual logistical barriers to accessing and continuing treatment, like getting a ride and having somebody watch your kids, and all that stuff. So not only is this a group that experiences a whole lot of judgment, but they also have a whole lot of barriers to getting into care. So I wanted to talk now about what is out there for treatment. So I'm going to focus on medication specifically for opioid use disorder, not because there aren't other medications for other substance use disorders, but the ones for OUD have really been the best studied, and particularly in pregnancy. So unfortunately for stimulant use disorder, we don't have good treatment medications yet. That's an area of like hot research right now. If you're interested in research and you want to research on methamphetamine and pregnancy, there's a lot of funding going into that right now. So if you're interested, we really need that information. Please, please do that research. Um, with regards to alcohol, there are good treatment medications for alcohol use disorder, but they haven't been well studied in pregnancy, unfortunately. But I'm going to talk about medications for opiate use disorder because that is by far the most common condition that we're seeing in our treatment program right now for pregnant people. Um, so there are a number of different medications that are used to treat OUD. This graph here shows in terms of the duration of action, so that dopamine stimulation and blockade of the opioid receptor activity with different substances. So heroin, very quick onset of activity. So the opioid receptor is stimulated, it does its thing with dopamine, and the person feels like great, like right away. And it's a pretty high receptor activation initially, and then it's a short-acting opioid, so it drops off really fast. So by the time that person is getting to like hour 2.5, they feel really bad if they have dependence on heroin. They now or on opioids. They now really need to be looking again to use. So heroin's a short-acting and it opioid, and it really triggers that use withdrawal, use withdrawal, use withdrawal pattern. In contrast, both methadone and buprenorphine are long-acting opioids, and they function very well, therefore, as treatment medications because although they have a little bit of slow onset to take effect, once they take effect, there's a very long and steady state activation of the opioid receptor. So if somebody's opioid receptors are screaming at them because they have opioid dependence, their receptors have a need for opioids, and they just used heroin and it wore off and they feel awful, giving them methadone, for example, will give them a sustained relief, and then they won't need to use again. So that is really the philosophy behind these opioid use. So agonists at the opioid receptor. In contrast, the medication naltrexone is an opioid receptor blocker. So what that does is it fills up the opioid receptor, but it doesn't give the person sort of the stimulation and euphoria that they would normally have had. So it's a great protective medication in that a person will not desire to use because they won't get an impact from it. But you can't give it to somebody until they have really withdrawn from an opioid because it'll put them in withdrawal if you give it because it's a blocker. So there are a lot of benefits of treating opiate use disorder with these types of medications. Methadone or buprenorphine are the two which have been best studied in pregnancy and are considered recommended medications. There's been some head-to-head research done looking at medications for opiate use disorder versus medically managed withdrawal. Not a lot of research, actually. So Turplin et al. In 2018 did a systematic review around this, and they didn't find actually that there was anywhere near enough research on it, but what they did find was not particularly favorable towards withdrawal or quote unquote detox from opioids as a strategy for managing opiate use disorder during pregnancy. So they found that folks that had medication for OUD, and by that I mean either methadone or buprenorphine, had reduced mortality and morbidity compared to people who didn't get treatment. And they had lower relapse rates compared to people who tapered off of opioids and tried to stay off of them. And they also had higher rates of engagement in care, probably because they were also receiving treatment medications. So they had a reason to engage with the medical system. They had a positive relationship. They also found that neonatal abstinence is less severe for newborns who are exposed to, say, methadone or buprenorphine versus heroin or other non-prescribed opioids. So we have over 40 years experience with methadone to demonstrate that, and then less so with buprenorphine, which has been legal in this country since 2000. We know that buprenorphine is equivalent in effectiveness, and it seems to have decreased duration and severity of neonatal abstinence or opioid withdrawal But it doesn't, we can't say that it causes less of it, just doesn't seem to be as long or as severe as for an infant who's been exposed immediately to methadone. So just quickly about methadone. Methadone is a full agonist medication, opioid, as you know. So when somebody has an opioid use disorder and they have an opioid receptor need to be stimulated with an opioid, the methadone fits perfectly into that opioid receptor. It does give them some euphoric effect initially, but after that, it's just a sustained reduction in craving and lack of withdrawal symptoms. So a very safe medication in terms of keeping people sort of stable once the dose is correct. You do have to work your way up slowly to a therapeutic dose with methadone, and that is actually the issue for folks who are, for example, on high dose fentanyl, that it takes a while to get up to a methadone dose that is effective. And so sometimes people have a period where they're still experiencing withdrawal symptoms because they're not on a high enough dose of methadone yet. The reason for that is not because our methadone treatment programs want to cause people distress. It's because methadone is very long acting, and if you give somebody too high of a dose, there'll be some left over the next day, and you can actually cause somebody a fatal overdose if you don't titrate it up very slowly over a couple of days each dose, or at least several days each dose increase. And there are strict rules about how quickly you can go up for that reason. So that's really a safety issue, and they do have to go up slowly. It's just hard for people who aren't getting treatment to the level of what they need yet. In contrast, buprenorphine is a mixed agonist antagonist medication. So it's a full agonist at the mu receptor antagonist at the mu receptor and agonist at the kappa receptor. It does cause a blockade of the opioid receptor, so that's good. It has limited euphoric effect for that reason, but it's excellent at preventing other opioids from sort of stimulating that receptor and making somebody feel euphoria. So buprenorphine, once established, is a very safe medication because it sort of takes the joy out of using other opioids. It's difficult to sort of break through that blockade. It's a strong, it binds very tightly to that opioid receptor. So if somebody uses, for example, oxycodone, they're not going to feel the effect of the oxycodone the way that they would if they weren't on buprenorphine. The other thing about this mixed agonist-antagonist effect for buprenorphine is that you can titrate it up quicker. It doesn't cause respiratory depression or overdose the same way that methadone does. So you can get to a therapeutic dose of buprenorphine within a few days. So that's actually an advantage of buprenorphine. The other huge advantage of buprenorphine over methadone is that methadone is very tightly federally regulated and can only be dispensed for the purpose of treating addiction in a federally licensed methadone treatment program. And so those are, in my neck of the woods, few and far between. There is one in the town where I practice, and the next one is about 2 hours away. So people, especially in remote rural areas, may have to travel, hours each way in order to get to a methadone treatment program. And methadone treatment programs are structured so that a person has to dose every single day, in person, observed. And so that obviously is a huge barrier to treatment in remote rural areas, or for people who have a job or who have childcare responsibilities or other reasons why they can't get up every morning and go to a methadone clinic and then come home and leave everybody else behind. Buprenorphine, on the other hand, although it is also a controlled substance, and providers have to apply, both midwives or physicians, APRNs or PAs, have to apply to the DEA to get a waiver to prescribe buprenorphine. It is something that we can prescribe from an office-based setting, and so people can actually go once a week, once every 2 weeks, once a month if they've been stable in treatment for a long time, get a prescription, fill it, and then they can give themselves the medication at home. So it's a much easier lifestyle on people to be treated with buprenorphine. I also want to talk just briefly about naltrexone. As I mentioned, it's a long-acting. I'm sorry, it's a long-acting opioid receptor blocker. So a full antagonist. There are two formulations, one of which is oral, that's dosed daily, and the other is long-acting injectable called Vivitrol, which is dosed monthly. And that naltrexone is also effective for the treatment of alcohol use disorder, again, because of its impact on opioid receptors and subsequently dopamine release. And so it's very often given to somebody who has both an opioid and an alcohol use disorder. And we have used the oral formulation in pregnancy for folks like in that situation. However, the big caution with any of these agonists, and also true for buprenorphine, is somebody has to be withdrawn from daily opioid use before they can be safely started on this medication, because otherwise you will put them in withdrawal. And then, of course, naloxone, which is a life-saving medication for opioid with overdose, which can be administered intranasally for that. It's also co-administered with sublingual buprenorphine in the buprenorphine naloxone formulation called Suboxone. And that is not orally bioavailable, so it doesn't cause withdrawal for that reason. There's been a lot of talk about whether plain buprenorphine or buprenorphine naloxone is safe during pregnancy, and the answer is both. The buprenorphine naloxone formulation was developed so that people, I should mention, buprenorphine is only administered sublingually. That's how it's effective, or by injection in a long-acting injectable formulation, but we won't talk about that because it's not approved yet for use in pregnancy. But buprenorphine naloxone, or trade names I won't go into, is administered sublingually. The buprenorphine naloxone formulation was developed so that the naloxone, if used by insufflation, which is snorting, or injection, would cause withdrawal symptoms in somebody, because naloxone is an antagonist that causes withdrawal symptoms. But if administered sublingually as prescribed, because naloxone is not orally bioavailable, it will be inert, basically, and the person will only get the benefit of the buprenorphine. So this mixed formulation was developed to avoid having people divert the drug and use it in a non-prescribed manner. The buprenorphine monotherapy was the first type of buprenorphine formulation that was studied in the initial studies. It is very safe in pregnancy, but from the sort of pregnant person exposure perspective, there really isn't a difference between that and the buprenorphine naloxone formulation. But we've used buprenorphine preferentially just because we have more data and research on it. So a lot of centers, including mine, have now gone to buprenorphine naloxone, but the buprenorphine monotherapy is still the preferred pregnant medication during pregnancy, sort of historically. It's just that now I think we're really understanding that it's equally safe to give the combination product. And there's some emerging data on that, and I've put a couple of the citations for that, equivalent safety there. The decision about whether a buprenorphine product or methadone should be used for a pregnant patient is really very individualized. So I mentioned before sort of the complexity of going to a methadone treatment program every single day and how hard that can be for someone. But for some people, for example, somebody who's not able to safely store a medication, somebody who's unhoused, somebody who has a partner who might use their medication or take it from them, or a place where it might be stolen, or where they might be attacked for it, then daily methadone is probably the safer medication for that person, because the structure of going to the methadone clinic every day puts them at less risk. So it's really an individualized discussion, and people should have, we should keep an open mind when we offer people options. I mean, availability is another one. If it's going to be a 2-hour drive each way to the methadone program, then that's a pretty easy decision for a lot of patients. They'd much prefer to try buprenorphine if they can. I will say that the high dose fentanyl use that we're seeing here in central New Hampshire right now is a complicating factor for this because buprenorphine anecdotally doesn't seem to be quite as effective for that at sort of holding people and keeping them safe. And methadone seems to be more effective because people's dose can be gradually increased to a place where it's therapeutic. This is an area we really need to be studying. I hope it's not true that we can't accomplish the same thing with buprenorphine, but right now in my community, it feels like we have more people on methadone for that reason. And then just a shout out to naloxone. So super important medication to get in the hands of our patients and in the hands of the community so that anybody who experiences an opioid overdose has a chance at a reversal. So if you're not familiar with it, it's a nasal spray packaged to reverse opioid overdose in community settings. The kits typically include 2 intranasal applicators. When you prescribe this or hand someone a kit, you have to also teach them about opioid overdose and naloxone administration. And then we do just want to highlight the ACOG committee opinion number 711, which says that although induced withdrawal may possibly contribute to fetal stress, naloxone should be used in pregnant women in the case of a maternal overdose, because obviously if you don't, she's going to die, and so might the will the fetus as well. All right. Unfortunately, access to treatment, particularly for pregnant people, is not readily available to everyone, and there are disparities in who can access treatment. So also, as obstetric providers, we are better at asking people about cigarette or alcohol use than we are about asking about drug use. And some of that can be due to sort of the legislative environment surrounding substance use or particularly drug use in pregnancy. So our colleagues at Johns Hopkins, Asita Patel and colleagues found that looking at PRAMS data, that states that had laws that identified prenatal drug use as child abuse or neglect typically had lower screening rates for substance use during pregnancy. So really the opposite effect of what we'd like, right? So an interesting correlation there between more punitive policies and lower screening rates and lower disclosure and treatment rates, therefore. We know also that pregnant people who are younger, less educated, unmarried, or Black versus white, and had public insurance were more likely to be screened for substance use than their counterparts, which is discriminatory, of course. ACOG does recommend a universal screening for substance use during pregnancy. So that means everybody, and also not just screen with toxicology, but to screen with a verbal validated screening questionnaire. Nationally, sadly, only 12.8% of pregnant people who needed treatment for a substance use disorder actually received treatment. That's a very recent paper by Martin and colleagues from 2020. And of those folks, Black and Hispanic women of reproductive age were significantly less likely than white women to get substance use treatment when needed. And in Massachusetts, this study specifically looking at treatment rates among pregnant people found that Black women with IUD were a third as likely as white women to receive medication for opioid use disorder, which we know to be the evidence-based approach. And Black women were also more likely to receive treatment with methadone than with buprenorphine. So disparities not only in access to care, but in access to the type of treatment medication. All right, so just some quick thoughts about managing medication for opioid use disorder during pregnancy. So the common side effects of any opioid, right, are constipation and nausea. And those two things are worse during pregnancy, of course, because they are pregnancy side effects anyway. Typically, people do need dose adjustment for both buprenorphine and methadone during pregnancy. So we can give our patients guidance that they actually will be expected to metabolize these opioid treatment medications faster as they get more pregnant, and they shouldn't feel bad if they feel like they need a dose increase in order to stay comfortable and manage their symptoms. That's to be anticipated. And I tell them, you know what, if we didn't change your dose, it would actually be like we were decreasing it. So don't feel bad. Like really from the fetus's perspective, it's the same as if you stayed on the same dose. We just need to increase it because you're burning through it faster. Patients definitely need education and anticipatory guidance about what the hospital's drug testing policies are, so what they can expect when they arrive in labor and delivery, what your institution's requirements are for length of stay for the baby, and what kind of surveillance for withdrawal symptoms the baby might have. It's important to tell them that there does not in the literature seem to be a correlation between buprenorphine dose and severity of neonatal opioid withdrawal. We don't know that for sure about methadone. And then it's really important to talk to them about pain management, which is a much bigger question we can get into if we have time at the end. So just some special considerations for initiating medication for opioid use disorder during pregnancy. We talked about the choice between buprenorphine versus buprenorphine naloxone versus methadone. This vexing question of where do you initiate a treatment medication if the person is pregnant. Really, in our institution, we make that determination based on whether they're under or over 20 weeks. So if they're over 20 weeks pregnant, we will admit them and start their treatment in the hospital so that we can watch their withdrawal symptoms and provide supportive care and do fetal monitoring. If they're less than 20 weeks, then we will start their treatment in the outpatient setting, unless they need admission for some other reason. Interactions. Methadone does have some interactions that are important to remember. So it is a medication that can cause a prolonged QT, and therefore we don't recommend co-administering it with, for example, ondansetron, which has the same impact. Contraindications, that's really any medication that causes QT prolongation. Methadone also interacts with some HIV antiretrovirals. Precautions, those are pretty much it. Concern for polysubstance use, benzodiazepines, and alcohol use are real important. If you're going to be treating somebody for an opiate use disorder, you want to make sure that they're not also physiologically dependent on something else that could cause them to be in danger. So benzodiazepine and alcohol withdrawal can be fatal, unlike opioid withdrawal. So it's really important to screen people for those. Concurrent tobacco withdrawal for inpatients is a big issue for our patients. If we admit them, we better give them NRT or some way to deal with their nicotine withdrawal, because otherwise they're going to be out of there really fast. And then there's an enormous amount of anxiety surrounding starting a treatment medication during pregnancy. Even for someone who's been actively using, they tend to be really anxious about how much withdrawal symptoms they will experience during the initiation process. And so we typically really try to help with that as much as we can. We'll often use hydroxyzine as a medication for anxiety during starting a treatment medication. All right. Any immediate questions, clarifying questions? I know I just went through that super fast. I feel like each one of these segments could be a full talk, so I apologize. I hope I'm not losing you. Questions? There's one in the chat. What is the estimated cost for treatment? Patients with food and housing insecurity would be able to receive treatment covered by Medicare, for example. Treatment medications are typically covered by Medicaid. They should also, I would think, be covered by Medicare, although I'm not as familiar with Medicare as I am with Medicaid. Because there is a requirement for parity. Now, each state's Medicaid eligibility is different. So there are some states that will not reimburse for treatment medications. I think they are fewer and fewer now because this is really clearly, the evidence is very clearly in favor of medication for OUD. How do you address use of marijuana in pregnancy and breastfeeding? let's save that to the end. And it's a really important topic to discuss. I agree. So remind me if I don't cover it. I just want to make sure that I talk about models of care. But I would like to talk about that at the end because I think cannabis use is the real tricky subject and something that we definitely need to be addressing with our patients. All right. So what is the best way to provide treatment for patients? Specifically now, I'm going to talk about patients who need substance use treatment. So the traditional treatment model, right, is that the patient gets prenatal care in one place, they get substance use treatment in another place, could be a methadone clinic, could be a buprenorphine clinic, could be a substance use counselor, but separate from their prenatal care. And then they get some mental health treatment, hopefully. And maybe they get some case management or some kind of social support somewhere, but these things don't go together and they're very siloed. So that's sort of like the traditional model. Integrated care models, on the other hand, try to bring all of these things together. So the substance use treatment is provided, co-located with the prenatal care, integrated with screening and mental health treatment, and hopefully case management or some kind of psychosocial support to meet patients' needs at the same time. And there are two sort of ways of thinking about integrating care. There's this sort of usual integrated care model where you have an OBGYN or a primary care clinic and you bring the addiction treatment and the behavioral health co-located into that clinic. Or you can have an addiction treatment program and bring your behavioral health and your perinatal care into that treatment program model. Either one is great. I would say there are some benefits to the addiction treatment model because people who have a substance use disorder may be going to a treatment program and feel that they have allies there. They may feel some trust with that program. And so bringing other medical services to a place where they already feel comfortable and rather than making them go to an entirely new environment can be more palatable in some circumstances, but equally good. So the key elements to either model are that people get their behavioral health needs met, they get some medications for opiate use or other substance use disorder and counseling and the other things that they need. They get some degree of social supports and case management. We find that having a recovery support worker, so peer recovery coach, is a critically important part of treatment effectiveness. And then, of course, it would be great if you have the resources for people to have a psychiatric evaluation and get their mental health needs treated as well. Our patients have told us that they find groups of peer recovery group treatment. So this is treatment with a licensed counselor as well as with peers in a group setting to be one of the strongest motivating factors for them. And this was because of the support provided by other people with the same lived experience, particularly if they're peers who have been in recovery for longer or peers who have had a baby and have custody of their child and can show that this is a possibility, really reduce people's anxiety. And then there was a lot of support that was administered sort of to each or provided to each other by people in the group that was endorsed by our research participants. And then they said, they felt when they saw somebody else sort of leading by example, that made it a lot easier for them to sustain their recovery. And when they, on the converse of that, when they used and had a relapse, a lapse or a relapse, and then they told the group, they felt bad about doing that, but they also got support for getting back on track from the group members. The other thing that I found this was really, really important was how much support patients provide for each other in trying to bring each other into recovery and even to sort of bring people into a program, and also sort of this sense of entitlement and gratitude for being in a program and the desire to make that available to other people. So our patients are really our biggest advocates for this kind of group treatment, and I think it's really important to follow their lead and to provide the service that they want. but also to help them be the ambassadors in the community for getting more people into care. So I think the strongest endorsement we can ever have from the patient is having them invite somebody else to the same program. The postpartum is truly a really vulnerable time for patients. So we lavish so much attention, not enough attention, obviously, but we do lavish more attention on pregnant people than we are on the parenting or postpartum person. And that is truly tragic because at that time, they're called upon to do even more in terms of caring for another human being, as well as maintaining their own self-care if there's somebody in recovery. And so adherence to treatment plan really falls off in the postpartum period, and we see a lot of relapse. That is especially high if a person has child protection involvement and tragically loses custody of their child. Factors which contribute to retention in treatment appear to be being able to parent a child, case management, for the methadone receiving population, having a methadone dose that's in the therapeutic range, so greater than 60 milligrams. And yet a 6-month retention rate in this study from Ohio was only 44%. A family medicine clinic in Maine actually had better retention rates, and that was providing an integrated care model where the person got all of their medical care as well as their buprenorphine, in this case, treatment. They were also treated with pharmacotherapy for depression, and it was the people who had their depression treated who got into treatment earlier on during their pregnancy and were able to achieve negative urine toxicology that were the most likely to be retained in care, and they had an 80% 6-month retention rate. So a shout out for integrated care there. At our Moms in Recovery program, which is an integrated program at Dartmouth-Hitchcock, our 50% retention rate begins to fall off really after the full postpartum year is over, as you can see from the survival curve here. I will say that not all those people have relapsed. Some of them have moved on to other treatment programs in their home community, et cetera, and some have tapered off the medication and do fine. So it's not that everybody who isn't in care with us anymore is doing terribly, but we do have a pretty good retention rate, and you can see that it does decrease stepwise. And the biggest drop in retention seems to be at that like 6 weeks to 3 months range, even for us. This is just a quick table showing what the outcomes are for our patients in our integrated versus patients who are cared for in our regular OB clinic but happen to go to a community-based treatment program. And we were able to show that our integrated patients actually did better in terms of prematurity, in terms of infant days in the hospital, which is of course related to prematurity, and also in terms of their urine toxicology at delivery. So we had less positive toxicologies at delivery in our integrated group than we did in the non-integrated group. So we feel pretty happy with these results in terms of supporting the need for providing integrated care options for patients. They do seem to really benefit from it. So if you have interest in that kind of a model, I encourage you to really think about it. This is an accepted manuscript now. It will be coming out in AJOG MFM sometime in the next few months. All right. Briefly, I want to talk about policy gaps. This is, to me, is really about how can we serve as advocates, as midwives, for the type of state and federal policies, and particularly state policies, because there's a ton of variation from state to state in this, that really support resilience. And we again went to our patients to ask them sort of what were the factors that seemed to them to support resiliency the most. And they were very clear that the pregnancy itself was sort of the internal motivating factor that brought them into care and got them initially engaged in recovery, but that it was the availability of external supports around that treatment. So, getting things like access to insurance, for example, so that paid for their treatment, support with transportation, help from case management, the peer support from the group that actually provided them with the ability to stay in treatment. So the internal motivation got them through the door. The support surrounding them enabled them to stay, and then they were able to develop sort of self-efficacy, sort of like, I turned it around. I'm making the changes in my life now that keep the people that are hurting me away from me, and only allowing the people who help me heal to be in my circle, and you know, sort of self-advocacy and self-efficacy in terms of how they manage their lives. And that all cumulatively led to the development of resilience. And I just really love this quote from one of our participants that, you know, people fall and make mistakes, but you can bounce back. It's not the end of the world to make a mistake, but how you react afterwards and pick yourself up is the important part. So that was sort of the take home for us, is that resilience is really about that bounceability. And it was a combination of internal motivation and external support that enabled that to happen. So what does that mean from a policy perspective? It means we need to have Medicaid coverage for people that doesn't end at 60 days after delivery. So we need to extend that coverage for at least the full postpartum year. Honestly, I believe in universal healthcare, and I think everybody should have access to healthcare as a human right. But we could start with making sure that we have continued Medicaid eligibility for the full postpartum year. Because that will allow people to stay in care, both for their substance use treatment and also for assessment and treatment of depression, for example, if they have that, and covering their other health needs as well. We also need to make sure that we have Medicaid coverage for critical services that are currently not reimbursable in many states, such as point of care case management, such as recovery coaches who are frequently not able to bill for their services, same with doulas, and community health workers and navigators, again, essential to patients' ability to access care, but they're not typically a covered service. And finally, you know, our program has found that we really need to be able to provide in our rural area people with phones, and we feel that something we're actually advocating with our New Hampshire legislature to make a covered service under Medicaid is to provide subsidies for cell phones. There are a lot of gaps in the continuum of care for patients. So clearly pregnant people are not getting access to treatment. You know, 12.8% of pregnant people being treated during their pregnancy is a ridiculous number. We need that should be 100% accessibility, right? They need immediate access to medication for opiate use disorders specifically. We need programs which accommodate children and provide childcare so patients can participate in treatment. We need residential programs that are trauma-informed and gender-specific. And we absolutely need housing, safe housing for people in all stages of recovery. All right, so in the last few minutes, I just want to quickly give a shout out to the Alliance for Innovation in Maternal Health, and then we can answer questions and start with that cannabis question. So thank you for asking that. I haven't forgotten it. So the Alliance for Innovation in Maternal Health, or AIM, is a national data-driven maternal safety and quality improvement initiative. You probably are all familiar with AIM, I hope. AIM works to reduce preventable maternal mortality and severe maternal morbidity across the US, and it's specifically using quality and safety implementation strategies. AIM recognizes the key drivers of maternal mortality and morbidity in this country by producing patient safety bundles for each of those key drivers. And unfortunately, one of those happens to be substance-related morbidity and mortality. So most states in the United States now are AIM states. We're super excited about that. We still have a lot of work to do to bring everybody else on board, as well as Puerto Rico, Guam, Samoa, Virgin Islands, and the Mariana. But we can. This has been an initiative over the past several years that's already achieved huge coverage. So there's still more work to do, obviously, but we're getting there. These patient safety bundles are structured along 5 sort of buckets of work. First, how do you get ready for whichever condition it is, be it hypertension or substance use? How do you recognize at the patient level that this is the condition that you're working with? How do you respond? What are the metrics that we should be using to determine whether or not we are making a difference, and how, making sure that we're doing a good job? And how do we provide respectful care? AIM has added this 5th bundle element of respectful care in the past year. I'm really excited about that. I feel like it really needs to drive everything that we do, and I'm so happy that it's an essential part of their safety bundle structure now. Each safety bundle also has an element implementation guide that goes with it, or will go with it, because some are still under development. Here is just an example in the safety bundle language. There might be under respectful care. This is from the substance use bundle, and I think this will be the final language for this particular bullet. Respect the pregnant and postpartum person's right of refusal for care, right, in accordance with their values and goals. And in the element implementation details, it defines what right of refusal actually means. So not only does the safety bundle sort of tell us what to do, but there's also a guide that tells us, like, sort of definitionally, what does that mean, and how can we try to, improve our practice in this area. So this would be a clinical pathway based on the AIM FED bundle, and I recommend going to the AIM site. So if you look for Alliance for Innovation in Maternal Health, there will be an announcement soon. I think at the end of October, there'll be a rollout for this FED bundle, and it'll be a webinar. I think a couple-hour webinar. Mishka Turplin will be one of the presenters, who's very worth listening to. Starting with screening and timely access to care, which we've talked about, then making sure we screen for medical conditions associated with substance use disorder, addressing social determinants of health needs, providing person-centered care, the anticipatory guidance we talked about, providing education and shared decision-making, and then respectful care, really focusing on anti-bias and anti-racism training for staff, using a trauma-informed approach to care for this group of patients, respecting a person's right to refuse care when they don't want it, and then a strong focus on harm reduction and making sure people have access to naloxone. So lots to talk about. I wish we had hours and hours. This is our New Hampshire AIM driver diagram. So how we've put together our work to achieve the elements in the substance use bundle. This is way too much to talk about at this moment, so I'm just going to quickly move on so we can get to questions. But I did just want to say, once you get a bundle that you want to implement, you do have to figure out a work plan, and this is the way that we've been thinking about it in New Hampshire. So here's a question that I just want to sort of leave us with. So what does a recovery-friendly healthcare community look like for our patients, and what is our role as perinatal providers? And I think what we should probably do now is just everybody open up your mic if you want to. I'm going to start initially with the question about cannabis use in pregnancy and breastfeeding, and then super happy to take other questions in the remaining few minutes that we have left. And I'm sorry to have lectured at you for so long, so thank you for your attention. Okay, so how do you address use of marijuana in pregnancy and breastfeeding? So we have had a lot of discussion in our program, because we are in New Hampshire, where cannabis use is illegal, and we are surrounded by Vermont, Maine, and Massachusetts, where it's legal. And so that's been challenging but I think in a good way for all of our providers here. So we've really tried to stick to what is known, what is in the literature about cannabis use, and try to be sort of as fact-based as possible in our counseling. So first we started by revising our policy on breastfeeding. So at Dartmouth-Hitchcock, we now do not tell people they cannot breastfeed if they use cannabis. We advise them about what is known about cannabis, about its transfer into breast milk, and potential impact on the newborn who's breastfeeding. And same for its potential impact on a fetus due to the presence of cannabinoid receptors starting at around, late first trimester, early second trimester. And the fact that there's much that isn't known about safety, but that longitudinal studies are not particularly reassuring. And so we recommend that for all of these reasons, especially the things we don't know, that we recommend that they do not use cannabis during pregnancy and they don't use cannabis while breastfeeding, but we still support them in breastfeeding as long as they're not like a daily heavy user. So that's how we're addressing it. I can't say it's perfect, but I think we're just trying to be as evidence-based as we can be.
Mm. Yeah, because my understanding, and obviously you're much more knowledgeable than myself, but my understanding that I've heard is that cannabis can interfere with neural connections, especially in infants during the second trimester when the brain is forming. And, obviously after birth, there's a lot of development in the first couple of years. So I think that it's an issue that's not well known by the community. And a lot of women today, they feel nauseous and they figure, well, I'll just use cannabis to help control my nausea without understanding that there could be side effects that could be harmful to the baby. So it seems that it would be helpful to get more of this information out into the general community, because I'm not hearing anything.
Yeah, I agree. I mean, I think the discussion that I have with patients is, we have evidence that we certainly have a biological mechanism by which it could harm the baby, right? Which is the presence of a cannabinoid receptor in the fetal brain. And the fact that this compound does bind to those receptors, right? We know that, right? Because that's what it does for you when you smoke it. But with all due respect, I cannot make you do anything. I can give you the benefit of the knowledge that I have based on the research that I've read. And I'm happy to answer any questions. My advice would be that you don't use cannabis for these reasons. And my desire is for you to have the healthiest possible pregnancy and the best possible outcome and healthiest possible baby, but it's telling people to stop using something is difficult to hear for a person. So it's really, I think, an area where using motivational interviewing is a really important thing. So benefits versus risks and helping a person sort those through in their own mind. The other thing that I do that I think is really important is try to be an ally in reopening a conversation. Never make it so that there's an oppositional discussion between you and your patient, right? But always allow that conversation to be opened again. Ask permission to have the conversation, and then ask permission to have the conversation again. The other thing I think that's really critically important is to ask the person, like, what is the role that this particular substance, whatever it is, right, plays in your life, right? Maybe it's tobacco, maybe it's cannabis, right? What can we do to help you treat your nausea in another way? How can we help you get to sleep at night without having to smoke a joint? Those are also like important questions, I think, because they empower the patient to say, well, I think the reason that I'm doing this is because I'm super anxious. Okay, well, let's talk about other ways to treat that anxiety then, so that you don't have to expose your pregnancy to something that we really are not reassured about and have inadequate knowledge about, the long-term potential impacts.
Yeah.
So
I'm wondering if it might be helpful to have more public service announcements on the TV, like we used to do about tobacco, or we used to do about the environment, and just so there's more awareness in our country, because it does seem like more and more states now are legalizing it. So now more and more people are using it.
Yes, and I think that's a really important point also, is that just because something is legal doesn't mean that it's safe to use during pregnancy, right? Or in all circumstances, right? And alcohol is a really great example of that. It's extremely dangerous, right? Substance if you're behind the wheel of a car. It's also extremely dangerous if you're pregnant. And sometimes people can see the correlation there. They're like, well, it's natural and it's legal. And it's like, well, yes, and that doesn't mean that you need to do it when you're pregnant.
Yeah.
Yeah, I think that respect is always a critically important element of any substance use counseling, like mutual respect for your patient and acknowledgement that they're an autonomous human being with the right to make their own decisions. You're just there to give them the information that you can. And, if they're willing to hear your advice, you can provide it.
Yeah.
Other questions or thoughts, comments? And this is kind of a whirlwind journey, sorry. Accessibility to caregivers seems to be an issue in some areas. Yes. Can you talk a little bit more about that? Do you mean like treatment providers or others?
That was just a thought that I had, because when we talk about accessibility of treatment, of medication, there's also, I had the same question about Medicaid or Medicare. I live in California, and we see the number of people living on the streets is increasing, and accessibility to healthcare is decreasing. Health insurance is expensive. And then you have all the exposure, let's say exposure to substances, and there are pregnant women on the streets. And we know that if we have providers, that increases the chance of having prenatal care, a more, sorry, I just heard some water noises up here. We can have, ideally would be having prenatal care well done. However, most of the time for those patients, we don't have the access, to healthcare provider or the medication. So it lacks the infrastructure, right?
Yep. So I think you bring up a number of super important points. I think for a situation where you're working with somebody who is unhoused, as many integrated services as you can provide is the way to go. I know for us, we have a number of patients who do come to our treatment program who are unhoused, and they seem able to come to one place. They don't always get there, but it's much easier for them to come to one place than it is for them to come to multiple. And it's also easier for them to come to a place where it's smaller and they know their people, and not to interact in a place where there are different people that they have to meet. They haven't met before, or a big medical center, so our treatment program's in a small space off campus, that seems better. I mean, ideally, of course, when caring for people who are unhoused, is to go to them and provide services there as much as you can. That's not a model that we're doing right now, but I have huge respect for it and believe in it.
Yeah, that makes sense. And also thinking about feeling safe, and also the trust, because most of the time those people, they're just so vulnerable to any sort of discrimination. So it's hard to open up and look for help, right? Yeah.
Yeah, for us, the use of peer navigators, the recovery coach, has been super effective with people who are sort of in the most vulnerable situations, because they,
Yeah.
the recovery coach is often the person who they'll find a way to text that person, even if they don't have a phone, they'll find a way to text that person or reach out or by Facebook and say, like, I'm thinking about getting back into treatment, like, can you help me? You know, when they wouldn't pick up the phone and call us. So it's a navigator, it's like, honestly.
Yeah, that's a good strategy. Yeah.
And that person also goes out into the community, so she will go to places where she knows people are staying and talk to them.
Yeah.
Great question. Yes, I will send my final slide deck, because I did make a few changes, of course, at the last minute, because I always do that, to Brittany, and she can send. It's fine to share them. I'll send them out. I did want to give you all my email. So I think we're at time, but here it is. And please feel free to reach out to me if you have any questions. I'm sorry about this. Was sort of a lightning trip through thoughts about perinatal substance use, but I'm happy to keep the conversation going. So please feel free to reach out.
Yeah. Daisy, I just want to say thank you so much for that fantastic presentation that you gave. I could really see you giving this to Congress, and I think, so much would be learned. I know that back in 1945, President Truman gave a speech to Congress and said, we could work on universal health care and maternal and baby health care should be one of our priorities. And it was not accepted at the time, but with all the transformation going on in the world, this might be a good time to work on it again. It won't get started right away, but I think you have so many great ideas in your talk that are so important. So kudos to you for a great job.
And I just wanted to jump in. This is Diana Jollis. Hi, Dr. Goodman. We have many DNP students here, and I want to make sure that they don't leave this presentation without knowing that you are the Dr. Goodman on the Squire paper. So Dr. Goodman, we didn't talk about this at all during this presentation, but she is one of the co-authors on the paper that all of our PC 744 students are using. You continue to inspire us every day. We have over 600 Squire papers that have come out. Yeah, so thank you. And we appreciate you.
Well, I appreciate FNU, and I have to say, and all of you, and I just thank you so much for inviting me and for the opportunity to talk about all this stuff, because there's so much to talk about. So thank you.
And I know everyone has said it, but I want to officially say thank you so much, Dr. Goodman, for a wonderful presentation, such really important information. And we thank you so much for sharing your time with us and your knowledge. And it was wonderful. Thank you so much.
Thank you for inviting me, and happy Midwifery Week, everybody.